Okay, so we're going to go ahead and continue on with the drugs for Alzheimer's disease, which they abbreviate as AD. So AD is the common form of dementia, and dementia is a progressive loss of brain function. So you can see below in this picture as it talks about what a normal brain, or not talks about, but shows what that normal brain looks like, and then the wasting away of the brain in a patient with Alzheimer's disease. So it talks about the neurons that die in those areas of the brain, and as we talked about with the other central nervous system medications, is that those neurons is where, those receptors release the neurotransmitters, and those neurotransmitters is what makes whatever function happens depending on the neurotransmitter. So there's many types and causes of dementia, and AD is just one of them. And it can be helped initially with drug therapy, and there do tend to be a genetic predisposition with the development of the problem around the brain neurons. So the protein beta amyloid is what builds up and forms deposits in the brain. Okay, and this is what they believe is the primary problem. So these microtubules in the neurons also become tangled and form non-functional messes in the brain. So the levels of the excitatory neurotransmitter ACH, which is our acetylchlorine, which we discussed with the prior CNS medications, these are decreased in the brain. So this results in more difficulty with their memory and their learning. So blood flow throughout the brain decreases, and over time these changes reduces in the size of the brain. So because we have less of the neurotransmitters, we have less of the blood flow, all of this is going to cause the changes in the shrinkage in the brain. Okay, so remember, if we're not getting blood to this area, is it getting oxygen? Is it getting nutrients? Can that area survive? So in addition to not getting those neurotransmitters. So the symptoms for the early on onset, they usually, the symptoms of early onset is usually to where a lot of times they mistake it for normal aging. But this is what you need to remember, and you should have learned this in PN 101, that memory loss is not a normal part of aging. So anytime someone starts having issues with their memory loss, they need to be checked out, because that is not a normal progression. So the disease is progressive. So what that means is that it continues to get worse. So the memory problems are going to become more and more challenging, and such as the beginning may be getting confused, okay, regarding times and places, or forgetting how to get home. They may leave to go to the grocery store and may not be able to find their way home. They also get changes in their mood, their judgment, and their personalities. So this is usually, the very beginning is usually that basic forgetting how to get home. And then it's going to progress on to where they forget how to walk, they forget how to talk, they forget how to feed themselves, they forget how to do just everyday things. So box 10.3 is going to show you your top 10 warning signs of Alzheimer's disease. So again, memory that disrupts their daily life, challenges in planning or solving problems. So it becomes very difficult for them to do everyday things, such as, going to work, or their hobbies, or paying the bills, or keeping up with just everyday things. They get confused about time and place. They have trouble understanding visual images. They start having new problems with words and speaking or writing. misplacing things and losing the ability to retrace their steps. And because they can't retrace their step, then they can't find the item that they lost because they don't know where they went. So they can't go look for it if they don't know where they've been. Decreased or poor judgment. They become withdrawn from work or social activities, and then they have that change in their moods and personalities. So, risk factors include older age, so greater than 65, a family history, and then having the APOE gene. So these are the things that cannot be changed, okay? And unfortunately, there's no single test that can diagnose AD. So what they do is they pretty much rule out everything else. They do physical examinations, neurological and cognitive examinations, and then they rule out everything else and they diagnose them with AD. So the only way to have a definite diagnosis of AD is to do a brain dissection after death. So the drugs that are used for AD is not cure. It's not a cure, y'all. It just kind of slows things down. It gives them temporary improvement, okay, in the symptoms. And so these drugs include your cholinesterase ACE inhibitors and your NMDA blockers. So the effectiveness of these drugs vary from person to person, just like with any drug, and the length of time for which the drug is therapeutic is limited, which means that it's going to work for a while, but then it's going to stop working. So the next table is going to list the most common drugs, and we're going to come back to that table because actually what we're going to do is kind of go through everything in the paragraphs, and then as we come back to that table, that is going to give us kind of just the breakdown in table form of what we discuss in these chapters. I mean not chapters, but in the paragraphs. So we have our cholinesterase inhibitors. So so these are the drugs that attempt to increase the acetylcholine levels. Okay, so remember, acetylcholine is that one of those excitatory neurotransmitters. So it's reduced in the brain of the patients with AD. So acetylcholinesterase is an enzyme that specifically breaks down acetylcholine. So we have acetylcholine, okay? That's the name of our neurotransmitter. And in that esterase, ACE, remember anything that ends in this ACE on the end means that it's an enzyme, okay? So this enzyme is what specifically breaks down the acetylcholine. So this cholinesterase inhibitor, okay, that means it's going to inhibit this enzyme. Okay, so remember, an inhibitor is something that blocks or inhibits something from happening, right? And so if this enzyme is what's breaking down the acetylcholine, and the acetylcholine is what we need in the brain of the Alzheimer's patient, then we want to have an inhibitor that's going to block that breakdown from happening. Okay, so it says that this is a drug that binds to the acetylcholinase and slows its action, which allows any acetylcholine produced to remain functional longer. Okay, so if this inhibitor is blocking this enzyme, then that means it's not breaking down the acetylcholine, which means more acetylcholine is being in that area that can be used. Alright, so this action appears to delay the memory loss and improves the patient's ability to perform their activity of daily living. So again, this drug is only a temporary fix. So as the disease processes, fewer intact neurons are available to even make the acetylcholine. And that's when the drug is no longer effective. So as we looked at this picture up here, as we have all these areas of the brain that's no longer there, then it's going to have less and less neurons to produce and to release that acetylcholine. And that's what makes it no longer effective. So it says 3 cholinesterase inhibitors are used in the treatment of AD. We have our Aricept or Danazepam. Hold on one second. Alright, so we have our first drug is going to be our Aricept. Okay, and then the generic for that is going to be donepezil. So donepezil. Okay, so that's going to be our first one. And then our second one, which is the brand name, is Exelon. And this Exelon, y'all, is usually in the form of a patch. And so we have the generic is going to be rivastigmine. 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 Okay. Then we have our last one, which is our brand name, is our Razidine. Okay, and then the generic pronunciation of that one is going to be galantamine. Alright, so some of the expected side effects and adverse effects of this category of drugs is going to be includes mild diarrhea, especially when they're first starting the treatment, drowsiness, headaches, and loss of appetite. Joint pain, muscle cramping can also occur. Cholinesterase. So our cholinesterase. Let's see. Cholinesterase inhibitors. Cholinesterase inhibitors. Cholinesterase inhibitors. Alright, so the expected side effects, again, we said mild diarrhea, and that's usually in the beginning, and it usually goes away with treatment as the body adjusts. So they can also, again, have that drowsiness, headaches, GI, muscle cramps. Okay. So our adverse effects are going to be hallucination, dysrhythmias, GI bleeds, infection, and difficulty urinating or incontinence. So again, remember, adverse effects are things that need to be reported that possibly can affect the drug may need to be discontinued. And then our side effects are going to be those things that we expect. So all these drugs, this category of cholinesterase drugs, are going to increase the acetylcholine concentration. So remember, what the drug is doing is it's blocking the acetylcholine from being broken down. So if it's blocking the acetylcholine from being broken down, then that means there's going to be more available for use by the body. So it says they're considered to be cholinergic agonists and can have adverse effects on the body, causing symptoms of overstimulation of the parasympathetic nervous system. So again, this is some common adverse effects of the cholinergic agonist and your cholinesterase inhibitors. So, cardiac can cause a slow heart rate, low blood pressure, heart block, and fainting. All right. Our central nervous system, it can cause convulsions, headaches, seizures, and sweating. Our GI system, it can cause increased secretions, increased saliva, abdominal cramping, vomiting, and diarrhea. Respiratory can have increased secretions and bronchospasms. And urinary, it can cause urinary incontinence. So again, these are adverse effects. So, all right. So next, our drug interactions. So our cholinesterase inhibitors should not be given with any drugs that can prolong the QT. Intervals on the EKG, because this can cause a fatal dysrhythmia known as torso de pointes. All right, so this is a form of ventricular tachycardia. So dextromethorphan dextromethorphan, which is found in your over-the-counter medications, quinidine, fluconazole, or three such drugs. Okay, so you do not want to give them with these drugs because they can have a fatal dysrhythmia. So you want to make sure that you consult your drug books to make sure that you know what interacts with different medications. Also, your anticholinergic drugs will decrease the effectiveness of the cholinesterase inhibitors. So you don't want to take any of the anticholinergic drugs, okay, because it's going to decrease the effectiveness of the drug. So if you take it also along with multiple or other cholinesterase inhibitors, then it's going to increase the risk of the effects, because if you take in more than one, they both are going to have the same types of adverse effects. So if you take two, it's going to increase it times times 2. So some nursing implementation and patient teaching. So you want to make sure you're getting a baseline weight management on your patient. You want to reassess this weekly because the drug can cause a loss of appetite. You also want to observe for signs and symptoms of GI bleed. So that's going to be things that is going to be your tarry stools, decrease in your H&H levels. You also want to monitor their baseline liver functions and BUN and creatinine levels to make sure that the drug is being metabolized correctly. You also want to assess the urinary patterns. You want to make sure and reassess any changes that may indicate side effects of the drug. Because remember, it said that the drug could increase incontinence or urinary retention. So we want to be monitoring how is their urinary patterns. Also, before the patient starts on the cholinesterase inhibitor, you want to assess the patient using the Alzheimer's disease assessment scale. So you want to know where are they before they start, right? And this assessment tool will be used to gauge whether the drug is being helpful or not. So if you don't have a starting point, remember we always have to have that baseline. If we don't have that baseline of that starting point, then it's not going to, we don't know if the drug is working or not. Planning, okay, we want to monitor for patients who have asthma. We want to make sure that the symptoms don't worsen. We're also going to check their vital signs and heart rates and look for adverse signs and symptoms, including that parasympathetic stimulation. And that was that box that we went over up above. So, evaluation, again, we're going to use that Alzheimer's disease assessment scale to see and monitor their vital signs for any adverse reactions. So, patient teaching. Okay, so we want to let them know that it may take several weeks for therapeutic effects. Okay, so that's not going to happen overnight. The drug is not a cure. We want to make sure that they understand that. Also, that if difficulty breathing, fainting, GI occurs, they need to notify the doctor immediately. Also, what is some of the expected side effects or cause if those expected side effects are causing more discomfort or new symptoms develop. Also, if they're using the bathroom every 2 hours to avoid urinary incontinence because the drug increases urination. Also, you want to let them know that Danazepam, they need to take that at night. Also, the other two medications, you want to take them at the same time, twice a day with food to avoid GI upset. Your risk for falls may increase because the drug can cause dizziness and weakness. And then keep all follow-up appointments. So it says a list of cognitive assessments and family information tools can be found at the Alzheimer's Association website. And so usually anytime somebody is diagnosed, the first thing that one of the first things that we do is also refer them to this website. There's a lot of information on how to handle the disease process, how to, education for the family, and, resources for things such as groups, that can be of good outreach and information for families. So the next medication is going to be your NMDA. blockers. Okay, so remember, anytime something's a blocker or an inhibitor, it's blocking something from happening, right? So when we talk about the actions and the usage, it's so it talks about we have the NMDA receptors in our brain, okay? And when these receptors are activated, the receptors allow more calcium into the brain neurons, so which appears to be important in memory and learning. However, too much calcium damages the neurons. So it's thought that the excess calcium is one mechanism that causes neurofibrillary tangles to form in the brain of the patient with AD. So the NMDA blockers are drugs that prevent the entrance of calcium into the neurons, which reduces or slows the neuronal damage in AD. So the thought is that the excess calcium is that mechanism that causes those neurofibrillary tangles. And as we learned at the beginning of this section on AD, this is one of the things that causes the damage within the brain. So these blockers, the NMDA blockers, they're going to prevent, that's not what I wanted to do. Is there a way to undo that? Okay, all right. So these blockers are the, why is it doing that? Okay, so they're the drugs that prevent, if they're blocking the NMDA, then it's blocking the calcium from getting into the neurons. Okay, so if the calcium's not getting in there, then it's going to decrease the tangles, or it's going to slow the amount of damage from those tangles. Okay, let me see something. Let's see if it lets me do. Okay. I don't know what's going on with this other one, why it keeps doing the... Okay, so if it prevents the calcium, then it's going to reduce or slow that damage to the neurons. So the drugs that is used to increase the effects of these, so let's see, we got our Numenda, which is the brand name that is used in the States. And then the generic is going to be, which is the most common that we're going to see nowadays, is going to be our memantine. Okay, so our memantine is our generic for our Namenda, and it's used with the drug. So usually anytime you have a patient on one of the prior drugs that we talked about, it's usually in combination with the Namenda or the memantine. Okay, so it's used with the what's the brand name? The cholinesterase inhibitors. Okay, so you're going to see a combination. You're going to see both of those used together. So they're used together, and they increase the effects of the cholinergic agonist. So expected side effects of the memantine are going to be your headaches, your dizziness, and constipation. And then our adverse reactions. So remember, those adverse reactions or adverse side effects are really the ones that we do not want to see. Okay, that's going to be hallucination, worsening, confusion, depression, somnolence, shortness of breath, incontinence, and weight loss. So it also can cause hypertension in certain individuals. So, if any of these things start to happen, then we need to notify the doctor, and then the doctor will be the one to figure out, is this because of the drug, or is this because of the progression of the disease. So those drug interactions, so any drugs that increase the urine pH or excreted by the kidneys, these can interfere with the renal excretion of memantine and increase the expected and adverse side effects. So if it's interfering with the excretion, then that means that you're going to have higher levels of the drug in the body. Okay, and if I have higher levels of drug in the body, then it's going to increase the adverse side effects. So carbonic anhydrase inhibitors such as acetazolamide, which are used for treating glaucoma and high altitude sickness, quinidine and dextromethorphan are examples of such drugs. So these two drugs are the same drugs that we had to be very mindful of with the other Alzheimer type medication. So assessment. So it's primarily eliminated by the kidneys. All right. So if it's eliminated by the kidneys, we have to be very cautious in people with kidney disease. Okay. Because if their kidneys are not functioning correctly, then they're not filtering out the medication completely. And again, those levels will stay high in the blood. And also people at risk for renal impairment due to age. And then people taking other drugs that also put them at risk for renal impairment. So we want to get a baseline measurements of their creatinine, their BUN, and their liver enzymes. Again, if we don't have a baseline, then it's very hard to compare anything. Also, urinary tract infections can increase the level of memantine by increasing the pH level. And then if patients showing signs of UTI, we want to obtain that urinalysis or that UA, and then we want to consult the healthcare provider before starting any drug therapy. We also want to monitor the respiratory rate and the vital signs, especially the blood pressure, because remember we said in some patients that it can increase the hypertension. And then we want to report any symptoms such as ataxia, dizziness, and any other adverse reactions. So ataxia is just difficulty walking, okay? So things we want to teach our patients, we want to tell them to give the medication at the same time every day. Also, we want the extended release capsules can be opened and the insides can be sprinkled if difficulty swallowing, but we just want to make sure they don't crush anything that's inside of the capsule, okay? Also, if they're using liquid, we don't want to mix it with any other liquids to avoid interactions. We also want to report any vision, rash, shortness of breath, agitation, confusion, dizziness, incontinence, and weight loss to the healthcare provider. You also want them to avoid driving or engaging in hazardous activities until they know the effect of the drug. And then report symptoms of urinary tract infection. So some of those symptoms can be that acute mental status change, frequency of urination, pain or discomfort on urination, concentrated or thick urine, and bad smelling urine. So you want to report all of these things to the healthcare provider. All right, so I'm going to stop here at this moment, and then I'm going to come back and do the drugs for epilepsy. But what I do want to go back up to is just remind y'all that the box up here is going to be those common drugs for Alzheimer's. Okay, we have our cholinesterase inhibitors. Okay, and then we have our NMDA blockers, okay, and then we have our breakdown of the two different types of drugs, okay. So we have three here under the cholinesterase inhibitors, okay, that you need to know about. And then your NMDA blockers is just going to be that one drug that you need to know about, which is going to be your memantine or your Namenda. And then remember, the nursing implementations is going to pretty much be the same for this whole category, okay? So if you are looking at the breakdown of these, again, we talked about the other day of how to break these down. I would take a sheet of paper, I would put my colon nesterase inhibitors up at the top. I would put my usage, what it's used for, would do my nursing implements over here. Also, I would do the side effects, adverse effects, and then what is going to be an easy way to remember the drug, like what does it end in, okay?